Good evening. Welcome from WebSankul Physiotherapy Alpha Batch. This is demo lecture for physiotherapy in neurological condition. So I am Dr. Chaitali Shah with 17 years of experience, and I am going to take all the lectures for the physiotherapy in neurological condition. These all are our team members who are going to take lectures on the various topics. This is the curriculum of physiotherapy in neuromuscular conditions. So curriculum is blended. It is having basic concepts, then assessment part and physiotherapy management part. So when we are covering the condition, some of the assessment part and physiotherapy management part I'll be taking, while the purely assessment part it will be covered in physical and functional diagnosis by Dr. Joel. So today we are going to cover the second topic, symptomatology of neurological disorder, and in this neurological disorder specifically stroke and Parkinsonism. These two conditions we are going to discuss in detail. So first is stroke physiotherapist perspective, which we are going to discuss. So stroke comprises of etiology, clinical features, classification, physiotherapy assessment, and physiotherapy management. So what teaching pedagogy we are going to use here is, first I'll be explaining some points which are important to solve MCQ, and then related to those we are going to discuss some of the MCQ. So stroke, as all of you are aware, there are two types of stroke. One is ischemic stroke and second is hemorrhagic stroke. So these are the differences between ischemic and hemorrhagic stroke. So ischemic stroke, it is common in 80 to 85%. It may be divided into thrombotic, embolic or lacunar infarct. While hemorrhagic stroke, it is less common. Only 15 to 20% of the people suffer from hemorrhagic stroke. Hemorrhagic stroke will be divided into intracerebral hemorrhage and subarachnoid hemorrhage. Now, each type of stroke, it has different mechanism, then some of the common causes and the key points which you need to remember to solve the MCQ. So, whenever there is obstruction to blood flow, it will result in ischemic type of the stroke. So, in thrombotic, there will be clot formation in the artery. So, when it may be asked in MCQ that what will result in thrombotic type of the stroke, then you have to write it is clot formation in the artery, or else thrombotic type is coming under, then you may have ischemic, hemorrhagic, lacunar, then you have to select the option ischemic stroke. So it will be clot formation in the artery. Then embolic stroke, it in this the clot travels from the heart or from the carotid artery to the distant location. And lacunar infarct, when small vessels in the brain they are occluded because of any of the reason, the most common reason is atherosclerosis, then it will result in lacunar infarct. Common causes for thrombotic stroke will be the thrombosis, embolism or lacunar disease. Then the predisposing factors which will result in this type of stroke will be hypertension, atherosclerosis, diabetes. Sometimes it may be because of arterial fibrillation or valvular heart disease, or it may occur in chronic hypertension or diabetes. Thrombotic, it is most common, as we have discussed, 80 to 85% of the people will suffer from it. Then it will have always sudden onset and deep brain structures, they are involved in the thrombotic type of the stroke. Hemorrhagic stroke, it may be produced because of rupture of the vessels, bleeding into the brain tissues and bleeding into the subarachnoid space. Now, common causes of the uh, hemorrhagic stroke, if we consider, it is chronic hypertension, it is trauma, it is ruptured aneurysm, and it will result in rapid onset with severe headache and increase in the intracranial pressure. So now related to this table, we are going to solve some of the MCQs. Now, before that, some of the predisposing factors for the stroke. So, predisposing factors, they are mainly divided into non-modifiable factors and modifiable factors. Non-modifiable factors which we cannot change, that includes age, gender, genetic, and previous history of stroke. While modifiable factors which include or which we can control up to certain extent. So, it include hypertension, diabetes mellitus, smoking, obesity, sedentary lifestyle, dyslipidemia, arterial fibrillation, and excessive alcohol consumption. So sometimes MCQs can be asked related to risk factors also. Now the first MCQ is the most common type of stroke is, as we have discussed, so our options are subarachnoid hemorrhage, intracerebral hemorrhage, ischemic stroke, and venous infarct. So guess what should be the answer? The answer should be the ischemic stroke. As we have discussed, ischemic is most common. 80 to 85% of the people suffer from the ischemic stroke. So answer will be the answer C. Second MCQ is lacunar infarct. They are commonly associated with. So the options are atherosclerosis of large vessel, cardioembolism, hypertension, and arteriovenous malformation. So the answer is lacunar infarct. It is very common with the hypertension. As we have discussed, one of the major cause for the lacunar infarct is chronic hypertension. So always hypertension will result in lacunar infarct. So our answer will be answer C. Now the next part which we are going to discuss will be the clinical features of the stroke. So stroke will result in direct impairment and indirect impairment. The direct impairment will be produced because of the area of involvement, and indirect impairment, they are produced because of the affected structures. So when particular artery, circle of Willis, you might have learned in the anatomy. So various branches of the circle of Willis, it supplies the brain, and when particular territory is involved, it will result in typical clinical feature. So when middle cerebral artery is affected, it will result in affection of face, arm, and it will result in aphasia. Anterior cerebral artery, when it is affected, it will result in weakness of the leg, and it may produce behavioral changes. And posterior cerebral artery, when it will be affected, it will result in visual defect. When vertebrobasilar artery, which is main artery, when these branches are affected, it will result in particular territorial involvement or clinical features, they are confined to particular extremity. But when the main branch, that is vertebrobasilar artery, if it is involved, it will result in ataxia, dizziness, or diplopia. Other features, clinical features, it include motor features. So motor features will be hemiparesis. So stroke will always result in hemiparesis on the opposite side. So say for example, right side of the brain is affected, then it will result in left hemiparesis or left hemiplegia. When it is just weakness, it is paresis. When it is total paralysis, it is plegia. So motor symptom, it depends on how much territory is involved or which area of the brain is affected, whether it is major affection or minor affection. Based on that, hemiparesis or plegia will be produced, and selective motor control will be affected. When stroke will occur, it is always result in increase in the tone because of the UMN type of lesion. So during initial few hours or up to 24 hours, there will be cerebral stroke which result in flaccidity, and then it will result in development of the spasticity. Then reflexes, it will result in hyperreflexia and positive Babinski sign. Sensory symptoms, it include affection of the superficial sensation, deep sensation or proprioception, and sometimes if the parietal lobe is affected, it will result in perceptual problem. Speech, whenever there is affection of cortex, it will always result in aphasia. So aphasia, it is the language disorder, while dysarthria, it is the speech disorder. This we are going to discuss in the upcoming slides. Perceptual problem, it will also sometimes occur in the stroke patient. Vision, whenever stroke will occur, sometime it will result in homonymous hemianopia. Balance, it will lead to affection of balance, specifically postural instability and frequent fall episodes, they are common. Coordination, stroke will result in ataxia, specifically when the lesion is present in the cerebellar area, and there will be functional affection which result in difficulty in performing ADL and walking independently. So based on the clinical features, now we are going to solve few of the MCQ. So the MCQ is Broca's aphasia is caused by lesion in. Option A is right temporal lobe. Option B is left inferior frontal gyrus. Option C is left occipital lobe, and option D is thalamus. So our answer will be left inferior frontal gyrus, because the Broca's area, it is located in the frontal lobe. So whenever there will be affection of frontal lobe, it may result in Broca's aphasia. Broca's aphasia, it is also known as expressive aphasia, and Broca's area, it is the expressive speech center which is present in the dominant frontal lobe. Okay, now we will understand what is difference between the Broca's aphasia and Wernicke's aphasia. As we have discussed, Broca's aphasia, it is expressive aphasia, where person will be able to understand everything but will not be able to speak. While Wernicke's aphasia, it is receptive aphasia, where person will be able to speak but will not be able to understand. So what is basic difference between the Broca's aphasia and Wernicke's aphasia? So speech fluency, Broca's aphasia non-fluent, effortful and halting will be present. Means patient will have difficulty in speaking. They will speak but in a non-fluent way. While Wernicke's aphasia, patient will speak fluently, but sometimes it will be meaningless or it will not be proper kind of conversation. Then comprehension, relatively preserved in Broca's aphasia, while it is severely impaired in the Wernicke's aphasia. So as I have told you, aphasia is the language disorder, and language is having three parts: comprehension, formulation and use. So here comprehension will be preserved in the Broca's aphasia, while comprehension, it will be affected in the Wernicke's aphasia. Repetition, it is impaired in both type of aphasia. Naming or difficulty in naming, which is known as anomia, it is impaired in both type of the aphasia. Reading, writing, they are also impaired in both type of aphasia. Then awareness of deficit, usually patient will be aware, but as patient understand everything but not able to speak, patient feel frustrated. So frustration will be common in patient with Broca's aphasia, while in Wernicke's aphasia, patient may unaware of his deficit. So that will result in less frustration as compared to Broca's aphasia. Associated motor deficit, so patient may have right hemiparesis, that is affection of face and arm, while in Wernicke's aphasia, there might not be severe weakness present along with Wernicke's aphasia. Typical behavior includes short phrases and slow speech in Broca's aphasia, while long sentences and jargon speech in Wernicke's aphasia. Area involved, as I have told you, Broca's area, which is located in the frontal lobe, that is area number 44 and 45. It will be affected in Broca's aphasia, while Wernicke's area, it will be affected in Wernicke's aphasia, which is area number 22. So this is basic difference between Broca's and Wernicke's aphasia. So based on this, we are going to discuss or solve the next MCQ. So patient with sudden loss of vision in one eye followed by hemiplegia most likely has. So we have discussed that ocular symptoms include homonymous hemianopia. So we will see what are the options. A. Vertebrobasilar stroke. B. Lacunar stroke. C. Internal carotid artery occlusion. And D. Subarachnoid hemorrhage. So answer will be C. When there will be affection of internal carotid artery, there will be symptom related to vision. Contralateral homonymous hemianopia suggests lesion in cerebellum, brainstem, occipital lobe and basal ganglia. So cerebellum, it will not have any visual area. Brainstem, it is connecting part. Occipital lobe, it is having visual area. And basal ganglia, again, it is the part of extrapyramidal system. So answer will be option C. Whenever there is affection of occipital lobe, it will result in homonymous hemianopia. So this is something about homonymous hemianopia. As all of you are aware about the visual field, we have two types of visual field. One is nasal half and the second one is the temporal half. In homonymous hemianopia, what happens? The same half of the visual field in both the eyes following stroke will be affected. Okay, so it will occur due to damage to the visual pathway. Visual pathway will be affected at the level of or beyond the level of optic chiasma. Optic chiasma is crossing. This is the crossing which is seen. It is optic chiasma. Okay. So whenever there is affection of optic chiasma, there will be homonymous hemianopia. It will be mostly seen in the posterior cerebral artery involvement. So PCA type of stroke will commonly produce homonymous hemianopia. So right visual field in both the eye. So it is always contralateral. What do you understand by contralateral? Means the lobe which is affected, homonymous hemianopia, will be on the opposite side. So here it has been explained that when left occipital stroke is present, it will result in affection of right visual field. So that's why it is known as contralateral homonymous hemianopia. Contralateral means on the opposite side. The next MCQ is Pusher syndrome occurs due to lesion in. Answer, it include options include cerebellum, posterolateral thalamus, frontal lobe and brainstem. So answer will be B. Whenever there will be affection of thalamic region, that is specifically posterolateral part of the thalamus, it will result in Pusher syndrome. In Pusher syndrome, it is reversal. Like in normal condition, hemiplegic patient will use sound side more to push. But in Pusher syndrome, what happens? Patient uses the affected side more to push, and that will result in frequent fall. And it will be produced due to affection of the thalamus, specifically posterolateral part of the thalamus. So this is the Pusher syndrome. Patient leans or patient pushes on the affected side. So this patient is having left side affected and patient bears more weight on the left side, and in standing also you can see patient pushes the therapist on the left side. So patient actively pushes towards the hemiplegic side or the affected side, that is the Pusher syndrome. Cause will be Disturbed vertical orientation relative to the force of gravity. Lesion, as we have discussed, posterolateral part of the thalamus. And key clinical feature, it include pushing on the uh, use of the unaffected limb to push towards the affected side. Next MCQ is unilateral neglect is most commonly seen with the lesion in. So what is unilateral neglect? It is patient is not perceiving any of the stimuli from half of the body. That is known as unilateral neglect. So options are left parietal lobe, right parietal lobe, left frontal lobe and occipital lobe. So unilateral neglect is part of perception or it is perceptual deficit. So whenever perceptual deficit are present, majority times parietal lobe is involved. So your answer will be out of two, that is A and B, left parietal lobe or right parietal lobe. But here it is always the non-dominant parietal lobe. So right will be always non-dominant hemisphere for majority of the people. So right hemisphere damage, it will result in neglect of the body or neglect from the space. So these are the various perceptual disorder which result in various perceptual problems. So first perceptual disorder which we have already discussed is unilateral neglect. What will be the key feature in unilateral neglect? Patient ignore one side of the body or space. Suppose one patient is having right side unilateral neglect, that patient may not be able to perceive any of the stimuli from the right side. Then body scheme disorder, in this poor awareness of the body parts. Anosognosia, patient will be unaware of own deficit, means patient will overestimate his capabilities in anosognosia and will have denial or lack of awareness about his own deficit. Constructional apraxia, it is difficulty in copying or drawing the object, means patient may not have orientation of various structures with each other, that is constructional apraxia. Dressing apraxia, difficulty in dressing properly, patient may not be able to put sleeve properly or patient may not be able to wear pant properly in the dressing apraxia. Visual agnosia, patient sees but cannot recognize object. So if you ask patient, patient will be able to see but will not be visually identify the object, that is visual agnosia. Astereognosis, difficulty in identifying object by touching. Say for example, if I'll manipulate anything with my eyes closed, say for example pen or key or coin, anything I'll touch, I'll be able to name that this is key, this is coin, okay. But patient with astereognosis, when they are manipulating the object with eyes closed, they will not be able to identify them. So that is astereognosis. Spatial disorientation, patient will have poor navigation in the environment. They cannot relate things with each other in the spatial disorientation. Finger agnosia, patient will not be able to identify the fingers. Say for example, when you ask patient to show his or her little finger, patient will not be able to raise it because patient is not aware which is little finger. And left right discrimination, patient confuses with left and right. So when you ask patient to touch right ear, patient will not be able to, because patient will have difficulty in discriminating the right and left. There are various areas. So majority time parietal lobe, right means non-dominant in majority of the people. What is dominancy? Say for example I am righty, so when I am righty, my left lobe is dominant. But when I am lefty, my right lobe is dominant. So majority for the righty people, their left will be dominant, and for the lefty people, their right will be dominant. So here the right parietal lobe, that is non-dominant lobe for majority of the people, it will be affected for majority of the perceptual problem. Only finger agnosia and left right discrimination will have affection of dominant parietal lobe. So this you have to remember, that majority of the perceptual deficit, they are present due to non-dominant parietal lobe involvement except finger agnosia and left right discrimination. So we have already discussed the difference between Broca's aphasia and Wernicke's aphasia. So now this MCQ is related to Wernicke's aphasia. So Wernicke's aphasia is characterized by, we have options: non-fluent speech with good comprehension, fluent speech with poor comprehension, mutism, patient will not be able to speak, and dysarthria only, that is speech difficulty. So the answer will be, Wernicke's aphasia will be always, speech will be fluent, but comprehension will be severely impaired or comprehension will be affected. So our answer will be answer B. Now we are going to discuss the synergy pattern. Synergy pattern, they are again form very important part in the stroke. So synergy pattern, they are mass movement pattern. Usually also we use synergy pattern to perform activities of daily living. Say for example, when we are eating, this is one of the synergy. When we are combing our hair, it is also synergy. So normal synergy we use in our daily activities or for our day-to-day life. But when any of the component of synergy will become abnormal, it will result in abnormal synergy pattern. And two type of abnormal synergy are identified. Synergy pattern may develop in the upper limb or in the lower limb. So flexor synergy and extensor synergy, they are the two kind of synergy pattern. So flexor synergy of the upper limb, it include shoulder abduction plus elbow extension, B, shoulder adduction plus elbow flexion, wrist extension plus finger extension, and shoulder external rotation and elbow extension. So if you want to remember the flexor synergy of the upper limb, you have to remember this pattern. This is the flexor synergy of the upper limb, where it will be shoulder will be abducted and externally rotated, elbow will be flexed, forearm will be supinated, and wrist and fingers will be flexed. So based on this, our answer will be answer B. Shoulder will be adducted and elbow flexion. So this will be produced because of the external rotation. Okay. So answer will be B. You can see in this picture 1, 2 and 3. This is neutral position. This first and second you can consider as flexor synergy, and the fourth one and fifth one you can consider as extensor synergy. So various components are described here. Whenever you are describing any of the synergy pattern, you have to explain about the scapular component, then shoulder component, elbow component, forearm component, and the wrist component. So shoulder, for the flexor synergy, it will be adduction and internal rotation. Then elbow will be in flexion, forearm will be in supination, and wrist will be in flexion. Okay. Any of the component may vary, which will result in mixed type of the synergy. And for extensor synergy, if you consider, the shoulder will be in internal rotation and adduction, elbow will be in extension, forearm will be in pronation, and wrist and fingers, they will be in flexion. Scapular component, so for flexor synergy, scapula will be retracted and elevated, whereas in the upper limb extensor synergy, the scapula will be protracted and depressed. So considering this, you have to remember that 5 muscles will never develop spasticity. One of those muscles, it include wrist extensors. So always in any of the synergy pattern, wrist and fingers, they will be in flexion. Same way in the lower limb synergy pattern. So whenever we are describing lower limb synergy pattern, we have to describe pelvis, hip, knee, ankle, foot and toes. So pelvis, for the flexor synergy, it will have posterior pelvic tilt or hip elevation or hiking. Hip will be in flexion, abduction and external rotation, as you can see in this figure. Flexion, abduction and external rotation. Knee will be again in the flexion as seen in this figure. Ankle will be in dorsiflexion, and foot and toes, they will be in supination and toes will be in extension. Now for the extensor synergy pattern, there will be anterior tilt or depression of the pelvis, as you can see, depression or anterior tilting, extension, adduction and internal rotation of lower limb, knee extension, ankle plantar flexion and pronation of the foot and toes, they are also in flexion. So again, everters of the foot, they never develop spasticity. So in any of the synergy pattern, if you see the foot posture, it will be always in the inversion or inverted foot posture will be present. So based on this, our MCQ is extensor synergy of the lower limb includes A. Hip flexion with knee flexion, hip extension, knee extension and plantar flexion, hip abduction and ankle dorsiflexion, hip flexion and ankle inversion. So our answer will be B. Hip extension, knee extension and plantar flexion. As it is extensor synergy, hip and knee both will be in extension. So clinical features we have discussed, etiology we have discussed, and we have tried to solve some of the MCQs based on those. Now the next part, which is very important from the physiotherapist perspective, is assessment of the stroke. So few of the MCQs based on the stroke assessment we are going to discuss. So before we go for the assessment, some of the commonly used or commonly administered scales for the stroke, they are mentioned here. So first scale is NIH stroke scale, which is also known as NIHSS. The component which it is going to assess will be the stroke severity. So it is also known as stroke severity scale. It assesses consciousness, vision, motor, sensory, language, and it is most commonly useful in the acute stroke. The second scale which is used for the stroke assessment is Fugl-Meyer assessment, that is also known as FMA. It mainly assesses the motor impairment. So Fugl-Meyer is commonly administered for assessing the motor impairments in the stroke patient. It evaluates upper and lower limb motor component, recovery, balance, sensation, and joint range of motion. Then next scale is Barthel index. Barthel index is used for activities of daily living. It measures the independence in dressing, mobility, personal hygiene, and day-to-day tasks. Then next is modified ranking scale. It is used to measure disability or functional outcome. It assesses the post-stroke disability, that is 0 with no disability, and 6 it will be result in death, that is severe disability. Then Ashworth or modified Ashworth scale, it is mainly used for assessing the muscle tone or spasticity. Then Bromstrom stages of recovery, they are used to grade the motor recovery, that we are going to discuss in the upcoming slide. Then motor assessment scale, that is MASS. It mainly assesses the motor function and activities of daily living. It evaluates the functional movement in the stroke patient. Then FIM, that is functional independence measure. which will assess functional abilities. It assesses physical, cognitive, and social function. So all type of functions will be assessed while we are taking FEEM. Then stroke impact scale, it is similar to the stroke severity, or it is also used for assessing the quality of life. So it is patient reported. Whenever we assess, there are two type of these scales. One is subjective and second is objective. Subjective is self-reported, where patient will describe uh, about the various component, and objective where therapist measure the deficit or severity. So CIS or stroke impact scale, it is self-reported scale which patient will report. And work balance scale, it is objective scale which therapist assesses. BBS, it assesses static and dynamic balance. Total score of the BBS is 56. It is gold standard test to assess the balance in the stroke patient. It also assesses the risk of fall in the stroke patient. So now MCQs related to the scales. So best scale to assess motor recovery after stroke. Barthel Index, NIHSS, Broomstorm Stages, and MMSC. So our answer will be Broomstorm Stages of Recovery. As we have already discussed that it will describe the motor recovery after stroke. Barthel Index, NIHSS is stroke severity, MMSC is for cognitive function, and Barthel Index is for the ADLs. So Broomstorm Stages of Recovery will assess the motor recovery after stroke. Then the next part is the Fugl-Meyer assessment primarily evaluates balance, cognition, motor impairment, or spasticity only. So as we have discussed, balance will be assessed with use of BBS, cognition by the MMSC, motor impairment, it include the joint range of motion and motor function by Fugl-Meyer, and spasticity by the modified Ashworth. So our answer will be answer C. So Fugl-Meyer is the gold standard test for the post-stroke motor impairment. Next MCQ is apraxia is best assessed by. Apraxia we have already discussed in the perceptual deficit. So apraxia can be assessed by asking patient to walk, asking patient to imitate the gesture, testing reflexes, and sensory testing. So testing reflexes and sensory testing, they are assessed by the therapist. So they are the objective assessment. So it will not be used to identify apraxia. Asking the patient to walk, that means when your patient is able to follow your command, patient is having good perception. But when apraxia is affected, patient will not be able to register what gestures therapist is making, and patient will not be able to copy it. So our answer will be answer B. Apraxia will be best assessed by asking patient to imitate the gestures. Now these are the stages of recovery according to the Broomstorm. So stage 1, it is flaccid paralysis where there will be no tone. It is stage of cerebellar shock. Stage 2, movement will be present in the synergy pattern and spasticity will just start emerging. So stage 2 where spasticity will emerge, in stage 2 you can see the associated reaction. Associated reactions, it includes Such's phenomenon and Ramsey's phenomenon. They are present in the stage 2 of the Broomstorm stages of recovery. Stage 3, voluntary synergy movement, producing movement across joint and spasticity will increase. So during stage 3, the component of synergy will appear and the spasticity will gradually increase. So there will be peak spasticity in the stage 3 and you will be able to identify component of the synergy pattern. Stage 4, voluntary movement outside the synergy pattern will start occurring. So spasticity will start declining from the stage 4. Patient may plateau at any time between stage 3 and stage 4. Stage 5, developing control of individual or isolated movement. So when your patient is in stage 5, patient will be able to perform some isolated component of movement. Say for example, if you ask patient to go for pronation and supination with 90 degree of elbow flexion, patient will be able to perform. And stage 6, it is return to normal motor control. So it is similar to or near to normal. So these are the Broomstorm stages of recovery. Now, appearance of spasticity corresponds to stage 1, stage 2, stage 4 or stage 6. So our answer will be stage 2. As I have already discussed that spasticity will appear in the stage 2 and there will be presence of the associated reactions like Such's phenomenon and Ramesses phenomenon in stage 2. Spasticity begins to decline in stage 2, 3, 4 and 1. So answer is very simple. Spasticity will begin to decline in stage 4. So answer will be C. Okay. So with this MCQs related to assessment, they are over. Now we are at the end part of the stroke management. So stroke management, it is multidisciplinary management and it require integrated approach. No single approach will be useful for managing stroke patient. So it is combination of neuro rehabilitative approaches plus the conventional therapy which we are giving to our patient. So these are the neuro rehabilitation approaches which include NDT or BOBAT, PNF, task oriented or functional training approach, constraint induced movement therapy, mirror therapy, robotics, FES or NMES, balance and postural training which is part of conventional therapy, aerobic or cardiovascular training, cognitive and perceptual rehabilitation, and speech and language therapy. So out of this, we will have separate session for all the neurorehabilitative approaches. So the next MCQ is best approach to facilitate normal movement pattern post-stroke. So which approach we are using mainly to facilitate normal movement pattern? First is roots approach, second is PNF only, third is BOBAT or upgraded version of BOBAT which is NDT, and fourth will be the strength training approach. So answer will be for facilitation of normal movement we are using BOBAT approach, which is principle of BOBAT approach where we are trying to inhibit the abnormal movement and we will try to facilitate the normal movement. For that we are using reflex inhibiting posture and reflex inhibiting pattern, which is the key concept of the BOBAT approach, which we are going to discuss in the upcoming sessions. Next is constraint induced movement therapy, that is CIMT is used to. What is CIMT? Where patient's unaffected hand or unaffected extremity is restrained so that the patient is compelled or patient is advised to compulsory use the affected extremity. That is known as CIMT. Another upgraded version of the CIMT is MCIMT, that is modified constraint induced movement therapy, which we can give in the home environment or home setting also. So CIMT is used to, first option is for reduction of spasticity, for improvement of balance, for improve use of the affected limb, and for treatment of aphasia. So our answer will be answer C. When patient is not using affected limb, we are forcing or we are compelling the patient to use his affected limb by restraining the unaffected limb. So patient has to mandatorily or compulsorily use the affected extremity. Mirror therapy is most useful in improving. Mirror therapy, it is based on the principle of activation of mirror neuron in the brain. It was deliver or derived from the monkeys. Monkeys are very good in imitating some behavior because of activation of mirror neuron in them. Same kind of neurons, they are there in the cortex of the human. So whenever we use mirror therapy, we are trying to activate those mirror neurons. So mirror therapy is useful in improving sensation, perception and motor recovery, spasticity and tone only. So no sensory feedback is given during mirror therapy, only vision is there. So visual feedback is given. So sensation, perception and motor recovery, spasticity and tone. So answer will be B, where perceptual aspect for motor recovery we are using while we are giving mirror therapy. Best intervention for neglect, that is unilateral neglect, is passive range of motion exercise, visual scanning training, strengthening of the unaffected side, and bed rest. So the answer will be B, that is visual scanning training will be most commonly used for the unilateral neglect. For aphasia rehabilitation, physiotherapist should A, avoid communication, speak loudly, use simple instruction and gesture, and let only speech therapist manage. So avoid communication is not an option. If you speak loudly but patient is not perceiving it, it is of no use. When you use simple instruction and combine with facial gesture, it may be useful up to certain extent. And role of physiotherapy is equally important in managing the aphasia. So our answer will be option C, where multimodal communication. What is multimodal communication? We are not using just verbal command, but we are using the facial expression or gestures to communicate with the patient. So that can be used. Now the next part is, this is with somewhat higher cognitive level. It is case based MCQ. So what we have discussed simply in the previous MCQ, it is somewhat twisted in the case based MCQ. So you have to analyze it and then you have to answer. So it is having higher cognitive level. First MCQ is, a 62-year-old male present with sudden right hemiplegia. So here the hemiplegia is right. So CV stroke will be on the left side. Aphasia means difficulty in speech and deviation of eye to the left side. CT scan shows infarct in the left hemisphere. So here the cause is also mentioned that it is due to the infarction. Which artery is most likely to involve? Okay, so opposite hemiplegia, aphasia and deviation of eyes. So we have discussed that eye deviation will be present in which artery? So it is middle cerebral artery. Answer will be C, middle cerebral artery, where contralateral hemiplegia, aphasia and deviation of the eye, it will be present. So MCA supplies motor cortex for the face and upper limb plus Broca's aphasia. So it will result in hemiplegia plus aphasia. So it is involvement of the middle cerebral artery or MCA territory. A patient shows fluent but meaningless speech, poor comprehension and inability to follow command. Lesion is likely in. So here they have described all the features of the aphasia. Now first we have to identify which type of aphasia it is. So speech is fluent but it is meaningless. Comprehension is also affected and patient is not perceiving it or patient is not recepting anything. So that is Wernicke's aphasia or receptive aphasia. So lesion is likely in the Broca's area, Wernicke's area, cerebellum or basal ganglia. So answer will be in the Wernicke's area. So this is somewhat twisted question. You have to identify which type of aphasia it is and then based on that Wernicke's area is affected, that you have to mention. Sometime which part of the hemisphere is affected, that can also be asked. So instead of Wernicke's area you have to write it is affection of the parietal lobe. Next question is 58-year-old female after stroke pushes actively towards the affected side and resists the correction. This phenomenon is called. So here some features of the pusher syndrome they are mentioned. Okay, and patient is also resistant for the correction. So whether it is neglect, it is apraxia, it is pusher syndrome or it is ataxia. So our answer will be simple, it is pusher syndrome. Pusher syndrome will be produced due to affection of posterolateral part of the thalamus. Next MCQ is, during assessment, the patient is unable to comb hair on command despite of good strength and comprehension. So the most appropriate diagnosis is, so patient is having ability to perform but the perceptual aspect is affected. So this is some perceptual disorder which is characterized by difficulty in following the command instead of good strength. So it is dysarthria. Dysarthria is speech related problem. Apraxia, it is perceptual disorder. Ataxia, it will be produced because of affection of cerebellum but which is not mentioned in this question. And agnosia. So our answer will be B, apraxia. Apraxia is inability to perform learned motor tasks despite of intact motor power. So following command will be difficult in case of the apraxia. A patient shows sudden reaction, elbow flexion, wrist flexion when attempting voluntary movement. This represent A, normal movement, B, flaccidity, C, flexor synergy and D, extensor synergy. So here you need to understand that shoulder is retracted and elbow is flexed, wrist flexion. So these are the elbow flexion, wrist flexion, they are the component of flexor synergy. In presence of flaccidity, patient will not be able to perform any of the movement. If it is normal movement, then it will not produce elbow and wrist flexion. So we have two options. Either it may be flexor synergy or it may be extensor synergy. So here the components are resembling to the flexor synergy as it is elbow flexion and wrist flexion. The answer will be C, flexor synergy. A patient can move out of synergy with difficulty, spasticity is decreasing and some isolated joint movement they appear. So which brainstorm stage is this? So we have to thoroughly understand what is asked in this question. Patient can move out of synergy. So stage 3, it is having synergy at the peak. Whatever movement patient will be doing in stage 3, it is with component of the synergy. But here what is mentioned, that patient is able to do movement out of synergy with difficulty, spasticity is decreased, and some of the isolated joint movement they appear. So the features are resembling to stage 2, 3, 4 and 6. So our answer will be, it will be stage 4, where spasticity will start declining and somewhat isolated movement is possible, and patient will move the limb out of synergy. So it is stage 4. Patient ignores food on the left side of the plate and shaves only the right half of the face. Lesion is most likely in. So patient is having neglect from the left side. So affection will be in the left frontal lobe, right parietal lobe, left occipital lobe and cerebellum. So as I have told you, unilateral neglect will be produced in case where non-dominant parietal lobe is affected. So the answer will be right parietal lobe, that is non-dominant parietal lobe. A therapist restrain the unaffected arm to force use of the affected arm during functional task. This technique is very simple answer. When we restrain the unaffected arm and force the patient or compel the patient to use the affected arm, it is known as Bobath rule, CIMT and PNF. So answer will be obvious, CIMT, that is constraint induced movement therapy. Patient shows impaired balance, wide base gait, intention tremor and dysmetria after stroke. The lesion most likely involves frontal lobe, basal ganglia, cerebellum and thalamus. So the answer will be cerebellum. All the features which are mentioned in the question, it is impaired balance. Okay, so balance is affected. Wide base gait, patient is walking with wide base of support. Tremors are present and difficulty in judging the distance, that is dysmetria is present. Then there are the features of ataxia. Ataxia will be caused or produced due to affection in the cerebellum. So our answer will be C. When cerebellum is affected, all these features will be produced. Post-stroke patient is unable to recognize common object placed in hand with eyes closed despite of intact sensation. This condition is, this we have already discussed. I have given you example that when I'll not be able to identify key, coin, pen or pencil with my eyes closed, although I am having intact superficial sensation, it is known as astereognosis. So options are neglect, astereognosis, apraxia and aphasia. So answer will be astereognosis, where patient will have difficulty in identifying the object despite of uh, the superficial or intact superficial sensation. Now the last part, this might be rarely asked, but if sometime it is asked, so I have tried to incorporate few of the image based MCQ. So first image, it shows identify the type of stroke. So here is the lesion. Okay, you have to identify which type of stroke is this: ischemic, intracerebral hemorrhage, subarachnoid hemorrhage and lacunar infarct. So it is obviously the intracerebral hemorrhage. When it is subarachnoid hemorrhage, this part will have the this kind of image. When it is lacunar infarct, very small area will show the infarct. And when it is ischemia, it will not affect this much large area. So it is always intracerebral hemorrhage. Second is which artery is affected in this infarct. So this area, it mainly supply the frontal lobe. So frontal lobe is supplied by middle cerebral artery. We have four options. Out of this, the large cortical infarct involving lateral hemisphere characteristic of the MCA territory involvement. So this second image shows affection of the MCA territory. Third, what impairment does this image show? Where child is not able to understand where to write. So the child is writing in the plate. So it is apraxia, dysarthria, it is unilateral neglect and ataxia. You can see the child is writing only on this side. This half of the plate is blank. So it is unilateral neglect. Instead of eating, child is writing. So patient ignore one side of the space, that is eat only from the half of the page and then using the plate to write. Which synergy pattern is this? So I have explained you when it is elbow flexion, wrist and finger flexion, it is flexor synergy. So this fourth image, it shows flexor synergy of the upper limb. Fifth is name the therapy shown in the image. So this is one of the mirror and patient is performing in front of mirror. So it is not CIMT, you cannot see any of the restraint in the image. No sensory clue is applied, so it is not roots approach. No electrodes are placed, so it is not tense. It is patient is performing movement in front of mirror, so it is mirror therapy. Sixth one is this test is assessing A. Proprioception, B. Visual field, C is DTR and D is apraxia. So here the therapist is assessing the proprioception. So option A will be our answer. Moving toe up and down, that is the small joint proprioception the therapist is assessing. So it is assessment of the proprioception. So answer will be A. Which visual deficit is shown here? Patient is only perceiving from half of the plate. So it is diplopia, homonymous hemianopia, astereognosis or agnosia. So half of the plate patient is perceiving from only one half of the visual field, that is homonymous hemianopia. The next is this cognition test is called Stroop test, Mocha clock drawing, Broomstorm test and tuck test. So Mocha is used to assess the cognitive function. So this is Mocha clock drawing test, which is shown in this figure. Which PNF pattern is this? So it is lower limb PNF, PNF D1 flexion. Bobath, it is not Bobath, it is not E-steam, it is not strength training. So it is PNF D1 flexion for the lower limb. And which stage of recovery is this? So stage 1, 3, 5 and 6. So if stage 1 is there, then patient will have flaccidity. So patient will not be able to sit independently. So it is not stage 1. Isolated movement patient is not performing. So it is not stage 5 or 6. So the answer will be stage 3, where patient will have some spasticity and synergy component will be present. These all are the references from where I have drawn all the MCQ. So you can refer all this book for more clearance of your concept, or all the answers or MCQs, they are based from this book. So Susan O'Sullivan, Umfred Darcy, Broomstorm, Karen Shefford, Shumway Cook, Adams and Victor, Principle of Neurology, and Deliza. These are the reference book. If you want to study it in more detail, you can refer this book. If you just want to go through, you can use Sullivan, which is simple and easy to understand. Okay. So with this, stroke part is over. Now we will move to the other part, that is component 2 of our today's session, live session. I hope all of you have understood stroke in proper way. You will be able to understand if you will hear this session again. When you are enrolled in this batch, we will have one-on-one doubt solving or query solving session also. So related to any of the question you have doubt, then once you will enroll, we can have doubt solving or query solving session also. So this is all about the stroke. Now we will move to the second part, that is the Parkinson's disease. So again, the same pattern or the same pedagogy we will use for the Parkinson's disease. So Parkinson's disease, it is characterized by akinesia or bradykinesia, tremor, rigidity, and postural instability. These four are the cardinal features of the Parkinsonism. Parkinson, majority of the sorry, majority of the cases, they are idiopathic Parkinsonism, means the cause is unknown, or um, there is no known cause behind the Parkinsonism. So that is idiopathic or primary Parkinsonism. And secondary Parkinsonism, the cause is something which will result in features of the Parkinsonism, that is known as secondary Parkinsonism. Some of the drug induced Parkinson symptom, they are coming under secondary Parkinsonism. Then vascular Parkinson, or due to vascular cause, if the symptom of the Parkinsonism they are produced, it is secondary Parkinsonism. Apart from this, Parkinson's plus syndrome is also there, where along with features, motor features of the Parkinsonism, you will have other systemic degenerative symptoms. So that is known as Parkinson plus syndrome. So we have to discriminate in the etiology whether it is idiopathic or primary Parkinsonism, or it is secondary Parkinsonism, or it is Parkinson plus syndrome. So etiology of the Parkinsonism. First question is, cardinal neurochemical deficit in Parkinsonism disease is due to degeneration of neurons in. Parkinson will be produced due to affection of the extrapyramidal system. So stroke, it is the pyramidal disorder or UMN lesion. This is extrapyramidal disorder where basal ganglia is affected. Basal ganglia comprises of 5 nuclei, which consist of caudate, putamen, globus pallidus, then thalamic nuclei. So putamen, caudate nuclei, substantia nigra, and pars compacta or globus pallidus. So Parkinson's will be produced due to affection of substantia nigra, pars compacta. Answer will be C, because when there is affection of dopaminergic neurons. Dopamine is the neurotransmitter which is present in the brain and which is responsible for controlling the movement. So whenever there is loss of dopaminergic neuron, it will result in affection of the receptors, or majority of the receptors they will be destroyed when clinical features of the Parkinson's will be produced, and that will be result in affection of substantia nigra or pars compacta. Clinical features of the Parkinson's disease appear only after loss of approximately. So just I have mentioned that when 70 to 80% or more than 80% of the dopaminergic neurons or dopaminergic receptors they are destroyed, then clinical features will be present. So 30 to 40% dopamine, 40 to 50%, 60 to 70%, and 70 to 80. So our answer will be D, 70 to 80%. So symptoms appear when approximately 70 to 80% of the dopaminergic neurons they are lost. Then it will result in clinically, you can say, marked features of the Parkinsonism. Levy's body are primarily composed of. So Levy's body formation will be common in the Parkinsonism. Now this Levy's body, they are made up of, or they are composed of, tau protein, beta amyloid, alpha synuclein, or dopamine metabolites. So our answer will be C. Alpha synuclein accumulation is result in pathological hallmark features of the Parkinsonism. Fourth MCQ is overactivation of which pathway is responsible for rigidity and akinesia in Parkinson's disease. So Parkinsonism will be produced. There are two type of Parkinsonism. One is rigidity predominant or tremor predominant, and another group of patient having postural instability. And two type of pathways are there. One is direct pathway and second will be indirect pathway. So overactivation of which pathway? Direct pathway, corticospinal pathway, indirect pathway, or cerebral pathway. So it will result in answer C. Always overactivation will be of indirect pathway. That will result in increased tone. So symptoms will be aggravated when indirect pathway is affected, and there will be akinesia or bradykinesia, or you can say the more tremor. It will be due to affection of the direct pathway. So indirect pathway, when it is overactivated, it will result in these features. Which neurotransmitter imbalance contributes most to the Parkinsonism tremor? So as we have discussed, it is the dopamine, which is centrally acting neurotransmitter. Same substitute at the peripheral nervous system will be acetylcholine. So disturbance in balance between dopamine and ACH, it will result in Parkinson's tremor. So dopamine serotonin, dopamine acetylcholine, that is dopamine and ACH, GABA and glutamate, and norepinephrine and acetylcholine. So our answer will be dopamine and acetylcholine. Dopamine is centrally acting, acetylcholine is peripherally acting at the level of neuromuscular junction. REM sleep, that is rapid eyeball movement sleep behavior disorder, is considered late motor complication, drug-induced side effect, prodromal feature of Parkinson's disease, and unrelated to Parkinson's disease. So it is late motor complication where ocular muscles they are involved, or there will be REM sleep behavior. So it is the uh, prodromal feature of the Parkinson. You cannot see it in the each and every patient. So it is prodromal feature of the Parkinson's disease. Next will be clinical features of the Parkinson's disease. So four cardinal symptoms we have already discussed: akinesia, bradykinesia, rigidity, postural instability, and tremors. Apart from this, many other features will be produced in the Parkinson's disease, like they have difficulty in speech. Dysarthria is very common. They will have some of the features related to the autonomic dysfunction, like they have seborrhea or siluria, that is drooling of the saliva from the mouth. They will have mask-like face, that is known as hypomimia. Then they have micrographia, their handwriting will become progressively small and unreadable. Then they have speech difficulty, Okay, then postural problem, it include phantom pillow appearance, that although no pillow is placed, their neck will be up from the supporting surface. So these are other features of the Parkinson's disease. So which symptom is least responsive to levodopa therapy? Tremor, bradykinesia, rigidity, and postural instability. So tremor, bradykinesia, and rigidity, they are somewhat controlled with the dopamine, but postural instability or balance issues, they cannot be controlled by levodopa. So our answer will be D, postural instability. It cannot be controlled, or it will not respond to levodopa in a way it should. Fascinating gait is best described as. So now, before going to the choices of this question, we will discuss what is fascinating gait. Fascinating gait, it is typical characteristic feature of the Parkinson disease, which is characterized by small shuffling steps. Patient will always try to chase his center of gravity. With stoop posture, small shuffling steps will be there. Patient will have difficulty in turning around. Patient will have difficulty in avoiding the obstacle. So when patient tries to avoid the obstacle, there will be freezing episodes. Then it may have retropulsive or propulsive characteristic. What is propulsive characteristic? That is forward accelerating characteristic. After walking few steps, you will feel that patient is trying to run. That is forward accelerating characteristic, that is known as propulsive gait. Retropulsive backward accelerating characteristic, that is known as retropulsive gait. Patient will have difficulty in dual task. So when patient is walking with holding a glass of water in hand, patient will have difficulty. Patient may lose the balance, or patient may have freezing episode. So all these are the characteristic of the fascinating gait. So fascinating gait is best described as wide base gait, ataxic stepping, short accelerating step, and high stepping gait. So as I have told you, patient will try to chase his center of gravity. So initial few small steps, followed by you will feel that patient is running. So short accelerating step, which is characteristic feature of the Parkinson's disease. So our answer will be C. Patients take progressively shorter and faster steps. Next is freezing of the gait is most likely to occur during. Means what condition will result in freezing episode. So I have told you, dual task, it will result in freezing episode. Or when patient try to avoid obstacle, patient will have freezing episode. Or when someone will call the patient and patient's attention will be drawn towards that person, there are chances that patient may develop freezing episode. So our options are straight walking, dual tasking, walking with cues, and walking on a treadmill. So option answer will be option B. While doing any of the dual task, when someone is calling, or when patient try to avoid the obstacle, or when something is hold in the hand of the patient, it will result in freezing episodes. Hypomimia in Parkinson's disease referred to. So hypomimia is speech disturbance, reduced facial expression, slow eye movement, and difficulty in swallowing. So mask-like face, as I have mentioned you, it is the characteristic feature of the late Parkinson's disease. And that mask-like face or reduced facial expression, it is known as hypomimia. So our answer will be B, where reduced facial expression, which is known as hypomimia, it will be seen in the patient with Parkinson's disease. Which symptom most strongly predicts the fall risk? tremor, rigidity, freezing of the gait, and micrographia. So micrographia is something related to handwriting, so it will not result in fall risk. Tremor, they are confined to upper limb, pill rolling type of movement, so upper limb involvement will not or will have less risk of fall. Rigidity, it is presented throughout the body, so our answer will be freezing of the gait. When patient try to walk from the freeze posture, it will result in fall or increased risk of fall. Bradyphrenia refers to, phrenia is something related to speech, so slow movement, slow speech, slowness of thought, or emotional flatness. So phrenia is thought will be affected or the cognitive process will be affected. So when slowness of the thought, that is cognitive processing, is affected, it will result in bradyphrenia. The etiology and clinical features of the Parkinsonism we have already discussed. Now the third phase of the Parkinson's disease will be physiotherapy assessment. So best outcome measure for executive function in the Parkinson's diseases. Executive functions, they are the higher functions or they are the more cognitive functions. So MMSE, FEAM, MoCA and Honyaher. So MMSE and MoCA, these two scales are used to assess the cognitive function. FEAM is for the functional activity and Honyaher is for the stages of the Parkinsonism. So out of MMSE and MoCA, which is best for the executive function in the Parkinson? So our answer will be answer C, MoCA. Why MoCA is best? Because MoCA focuses more on the frontal lobe related executive function. Most sensitive test for functional mobility and fall risk in Parkinson's disease is 10-meter walk test, Berg balance scale, time up and go test, and functional reach test. So functional mobility and fall risk. So 10-meter walk test, it assesses the mobility plus cardiorespiratory endurance. Berg balance scale, it assesses the balance. Time up and go test, it assesses the mobility and fall risk both. And functional reach test, it assesses only the static or dynamic stability. So our answer will be C, time up and go test. It assesses both functional mobility and fall risk in Parkinson's disease. Horn and Yaher stage 3 represent. So there are 5 stages of Horn and Yaher. In stage 1, there will be just neck rigidity. Stage 2, neck rigidity and posture will be affected. Stage 3, rigidity will be there, posture will be affected, some of the lightning reactions are affected. Stage 4, patient will have more severe symptom, patient is confined to wheelchair. And in stage 5, patient will be confined to bed or mobility is severely hampered in stage 5. So unilateral disease, that will be stage 1. Bilateral without loss of balance. Postural inability but independent, and D is wheelchair bound. So our answer will be C, where postural instability will be there but somehow patient manages to maintain his balance. So patient is independent for all the activities of daily living. Which assessment best captures the freezing severity? UPDRS, PDQ-39, freezing of the gait questionnaire, and Barthel index. So freezing of the gait questionnaire FOGQ will be assessing the freezing severity. UPDRS and PDQ-39, they are Parkinson specific scale, and Barthel index, it is for the activities of daily living. Which test best measure the endurance limitation in Parkinson's disease? TUG, 10-meter walk test, 6-minute walk test, and MMSE. So 6-minute walk test will be used to measure the endurance. Dual task deficit in Parkinson's disease is primarily due to impairment of muscle power, sensory input, executive function, and vestibular symptom. So our answer will be C. Executive function, when they are affected, the patient will have difficulty in performing the dual task. So frontal basal ganglia dysfunction will result in dual task deficit, and that will be produced in the patient with Parkinson's disease. Now the last segment of this session is physiotherapy management related MCQ. So again, the Parkinson's management, it require multi-dimensional physiotherapy management, which includes stretching, strengthening, then some of the management of some of the autonomic symptoms, also facial mobility, cardiorespiratory endurance. So first MCQ is, why does cueing, that is either visual cueing or auditory cueing, improve gait in Parkinson's disease? So cueing, whether it will strengthen the muscle, it will increase dopamine release, it will bypass the basal ganglia via cortical control, or it reduces spasticity. Answer will be C. It will bypass basal ganglia via cortical, alternative cortical motor pathway. So whenever you are using either auditory or visual cue, you are directly stimulating the cortical areas. So you are bypassing the basal ganglia or the extrapyramidal system, and patient will be more relying on the command which are received from the cortical level. So it will result in improved gait. So whenever you are giving gait training to the Parkinson's patient, you have to use either auditory cues or visual cues. Best evidence supported intervention for improving gait speed in Parkinson's disease: passive stretching, strength training, treadmill training with cueing, and electrotherapy. So our answer will be C, treadmill training with cueing, because there the patient is walking on the treadmill. If patient is having affected balance, then you can give harness to support the body weight, and you can give body weight supported treadmill training that will help the patient in improving the gait. Exercise should preferably perform during. One of the very important terminology for the Parkinson's patient is on-off phenomenon. What is this on-off phenomenon? During certain period, the patient will have uh, more effect of the medicine, or patient will be more responsive to the drug, and during some time the response to the medicine will reduce. Okay, so after taking medicine, when the drug is at its peak reaction, you should advise patient to do the exercise. So early morning, off phase, on phase, or any time. So on phase, that is 45 to 60 minutes post medication. This is the time where the effect of drug will be maximum. There will be temporary reduction in the rigidity, and patient can perform his best during this on phase. So on phase is the duration where you will get maximum response or active participation from the patient. So during on phase, you have to give your physiotherapy session. Which strategy is best for managing the freezing gait? Avoid walking, mental imaginary and cueing, and strengthening only, or bed rest. So mental imaginary and cueing, it is the best strategy for managing the freezing gait. Patient will imagine that he is walking, So mentally imaging that and you are externally giving some cueing, it will help in overcoming the freezing episodes. So B will be our answer, that visual clues plus tapping over line and metronome, they are effectively used. Metronome is walking with the beats. Which intervention improves postural instability most effectively? Passive range of motion, static balance, dynamic balance training with perturbation, and bed mobility exercise. So our answer will be C. Dynamic balance training with perturbations will be most helpful for improving the stability. Which great gait training technique improves reciprocal arm swing? So arm swing is the associated with heel strike and phases of the gait cycle. This automatic movement like arm swing will be affected in the patient with Parkinsonism. So if you want to train your patient for reciprocal arm swing, which is the best method, walking in the parallel bar, two stick technique as mentioned in the Dina Gardiner. Therapist is just besides the patient. Therapist is holding two sticks. Patient is holding two sticks, and then therapist and patient both simultaneously moving the sticks forward and backward. So it will facilitate or it will promote the arm swing. Then resistance band training or orthotics. So answer will be two stick technique, which is mentioned in the Dina Gardiner under the Frankel's exercise. So this technique will be best for promoting the arm swing in the Parkinson patient. Most important long-term goal of the physiotherapy in Parkinson's disease is cure the disease. This is neurodegenerative disease, so cure is not possible. Only symptomatic management or controlling the symptom or managing the symptom will be the main priority of the physiotherapist. Increase dopamine level, prevent secondary complication and maintain the participation, and eliminate the tremor. So prevent secondary complication and maintain participation will be the main goal, long term goal from the physiotherapy perspective. So this was all for today's session. I hope you have cleared many things about the stroke and Parkinsonism. If you want to attend such more sessions for physiotherapy in neurological condition, you can join physiotherapy alpha batch. The details they are given in this slide. You can enroll yourself in the physiotherapist alpha batch and you can attend more sessions where we will cover all the topics which is mentioned in the syllabus, and we will have doubt solving sessions also. We will provide you assignments also for self solving. 25-30 questions from each topic will be given to you, so you will receive the notes of this lecture as well as the assignment. So please join physiotherapist alpha batch to attend such more sessions. Thank you very much. Thank you.